Getting started, but we made sure that we all called each other and said, should we be blue today? Because you know when you don't match up, it's kind of hideous. And this is a team event. And we must do a fantastic job because this is a jet-setting world traveler, loves horses. She's got the seemingly dinky little annular tear, but it's causing huge problems, including pelvic dysesthesia, back pain, and leg pains. And if you're wondering how we know this dinky little lesion is causing the symptoms, we did a targeted injection with both an anesthetic and a steroid. And she got better during the diagnostic phase in the first 4 hours when the anesthetic is working, and for another 3 days thereafter, but unfortunately the symptoms came right back. And this is the first time someone's been able to identify the cause of her pelvic dysesthesia. So we're pretty excited. So hopefully my minimally invasive laser endoscopic discectomy and annuloplasty going through a little poke hole will get her back to living her wonderful life as soon as possible. So wish me luck. Shot and save. There's the annular tear right there. It's like a little, I don't know, it looks like a little mushroom. Oh, that's so perfect. I bet you we're going to see that really clearly. The inner part of the ligamentum flavum deep. The ligamentum flavum becomes the facet joint capsule. But most of you are like, I have no idea what you're talking about, so don't even think about it. Don't worry about it. I'm just talking out loud because I operate better when I talk out loud. This ligamentum flavum with the laser. Because the other way to do it is mechanically with a biting basket. Guess what happens? A bunch of pieces start floating around and getting in our way. And it's messy. And you know me, I hate messy. I hate blood, I hate messes. We're all blue here. Here's the bone of the lamina of S1. This is really tight right there. If there's stenosis, that's the greatest amount of stenosis right there. Look at all these little filmy tissues. Okay, so there's the traversing nerve root. Look at that thing pulsate. Look at how many blood vessels there are on there. And then that's the disc. And I'm using the cannula now to gently scooch the dural tube and nerves out of the way as I slowly make my way to the middle. And now you know why I like that blue dye. Come on. That's pretty, I'm sorry. Look at all these little adhesions. This maneuver right here also releases everything. And look at that, there's the tear. And that's our neuromonitoring physician. His job is to annoy me. If he's not annoying me, he's not talking too much. Oh, he's getting really annoying. So this is in the middle of the disc, exactly where it's supposed to be. Look at that blue dye. It pinpoints the central part of the tear. And look at that, totally empty tensine. Right there. And there it is. That should be a thick wall of white. If it's blue, that means it's been torn and the blue dye is leaked out and stained the collagen tissues within the annulus. Okay, this is what an annulotomy window is. It's pretty small compared to regular traditional open surgery. But check out what I can do. I can just go a little bit deeper. I can rotate the cannula to get things out of my way. And you can see the annular tear right there, look. Going straight up. Oh, it really is the little things that keep you going, don't you think? Oh, this is going to be gratifying, I can tell. In kind of that kind of weird way where when you pop a pimple and that big thing hits the mirror in your bathroom, it's so kind of, I don't know, it's a little disturbing, but at the same time, it feels so good. You know what I'm saying? That's what this is right here. Look at that. Oh, yes. It should not be busted up like that. Because the annulus should be like a steel-belted radial tire. It should have dense, crisscrossing collagen fibers that creates a wall or a barrier for all the nucleus to leak out. But when it tears and fissures, this happens. Going straight up and very gently feeling for any loose pieces. And there's a big piece right here. I can feel it right there. Oh, look at how much stuff there is. Okay, this may be a really good picture of an annular tear. You can see the white part of the annulus. I mean, back here it's all white. Look at that right here.
Small train of spines.
And watch what this is going to look like. You'll see a fissure going straight up. Look at that right there. And it comes straight out right here. And the surgery is to basically remove the offending agent, so pieces of nucleus trapped inside this fissure, and then have the fissure start a new healing reaction without all those trapped pieces of nucleus. And then it will go through its normal healing process where the inflammatory process of healing turns on and turns off. And in cases of a pathologic painful annular tear, I think it's because when the annular tear develops, the body heals it, and in some patients, it gets stuck in the inflammatory phase of healing. And when you do this surgery, remove the offending agent, start a new healing reaction, just statistically speaking, hopefully, this time it'll go down the correct path where inflammation turns on and turns off. Look at all this injection. Like, that's way too many blood vessels for right here. And that's where I've been looking underneath. And I'm pushing down on it now using like a pimple popper. And when I do this sometimes, and look at that, you can see, that is so cool. You see exactly where it ends. And I'm pushing down on it, so if there's any more in there, it would come squirting out like a hot pimple. I got it, baby. And clearly the dural tube is free too, because I just moved it over. So now I just got to get the undersurface of that blue thing right there. And then on your way to your new life, I hope. Oh, look at that thing come flying out. Oh, all of a sudden that's looking so much better. Nope, there's something right here. Yep. Part of what makes this surgery is that in most open surgery, we're like looking at this with our naked eye and we can just feel it and grab it. Endoscopic surgery, it's two-dimensional, and this tactile field is feeling like, oh, there's something right there. I rely on that a lot, and imagine how hard it is to teach somebody that. Feel. It's like the golf short game. You have to practice. We call this the Mikey fragment. It's the last piece of hidden fragment that right before I'm done, the piece comes flying out. This tear went all the way across, but I feel very good that I took out not too much, not too little, just the right amount. The nerves are totally free and mobile now and pulsating. And on a side note, they're not injured. If you're wondering, how do you know? Look at that thing. That is one happy looking dural tube. And if you were to see me, you'd see one happy looking surgeon. I like it. Surgery's all done. It went beautifully. I found so much badness. So I'm really expecting a great result. And we're all praying for a speedy recovery. After I put this dinky little thing on, normally I put a Band-Aid in, but I know you're sensitive to Band-Aids, so we're going to put Telfa with paper tape. Oh, that's adorable. Hey, that's the first time I've used this. I kind of like that. It doesn't have the same effect as a Band-Aid, but still, that's adorable.